Okay, I want you to picture this. You're in a liver transplant operating room. It's one of the most complex surgeries there is. And for the team managing that patient's blood, it's like walking a tightrope over a minefield. The stakes are just unbelievably high. You make one wrong move, you could have massive, uncontrollable bleeding. You make another, you could cause a fatal blood clot. It is the ultimate physiological balancing act. And that right there brings us to the absolute core puzzle we're tackling. It's a question that has honestly confused clinicians for decades. Patients with severe liver disease, they're a walking paradox. Their bodies look like they're all set up to bleed. But at the very same time, they are dangerously at risk of forming deadly clots. So how on earth is that possible? Let's get into it. So if you just look at the surface, everything points one way, bleeding. You look at the standard lab tests, a high INR, low platelets, and they are all screaming major bleeding risk. But the reality, it's so much more complicated. See, the sick liver, it's not just failing to make things that help you clot, it's also failing to make the body's natural anti-clotting stuff. So what you get is this bizarre rebalanced system. It's not necessarily weak, it's just incredibly fragile. It can tip violently one way or the other with just the smallest nudge. So, here's how we're going to unpack this whole clotting conundrum. First, we'll really dig into that rebalanced paradox. Then, we'll see why our old tests just don't give us the full story. After that, we'll meet the technology that basically writes a clot's biography, ROTEM. We'll see how it's changing treatment right at the bedside, and then we'll look at the tricky new risk that this amazing precision has uncovered. All right, let's start by digging a little deeper into this whole idea of a fragile balance. Because really, if you get this concept, everything else is going to click into place. And here's the official name for it: rebalanced hemostasis. You know, think of it like a tug of war where both teams suddenly lose half their people. The rope might not move much, but that balance is super precarious, right? The body is walking a tightrope. On one side, you've got catastrophic bleeding, on the other, life-threatening clots. It's a brand new and very unstable normal. So if this rebalanced state is real, why did it take us so long to really see it? Well, the answer is pretty simple, actually. The tools we were using were giving us the wrong information. And look, this isn't a new idea. This quote really sums up what doctors in the OR have known for years. Our conventional lab tests just aren't built for a crisis. They're way too slow, and they just can't show the dynamic, complex dance that's actually happening in a patient's blood. Let's break down exactly why they fall so short. First, they're slow. I mean, an hour for our results? That is an eternity when someone is bleeding out. Second, they're incomplete. They only look at a few clotting factors floating in plasma, totally ignoring the huge role that platelets and other cells play in whole blood. And because of all that, they end up being really misleading. They often push doctors toward a sort of blanket transfusion of plasma, just in case, which, it turns out, might not only be useless, but could actually be harmful. So we needed a better way. We needed a tool that's fast, that's comprehensive, and gives us the real story, right there at the bedside. And that is where ROTEM comes in. I absolutely love this analogy because it just makes the difference crystal clear. Think about it. Standard tests are like a couple of random snapshots from a construction site. You might see a pile of bricks or a single worker, but you have no idea how the house is actually being built. ROTEM, on the other hand, it's the full time-lapse video. You see the foundation being poured, the walls going up, how strong the structure is, and you even see if it starts to fall apart too soon. You get the whole story. So formally, ROTM, or Rotational Thromboelastometry, is what we call a viscoelastic hemostatic assay. But really, the key things to remember are point of care, which means it's done right there, not in some far-off lab, and graphical representation of the entire life cycle. It's not just a number, it's a visual story of your clot. And that graph, that visual story, has 4 key chapters. First up is the clotting time, or CT. That just tells us how long does it take for this story to even begin. Then you get the amplification phase, the clot formation time and alpha angle, which shows how fast and strong the clot builds up. Next is the climax, the maximum clot firmness, or MCF. This is the clot's peak strength. And finally, you get the ending, maximum lysis, or ML, which tells you if the whole thing falls apart too quickly, a really dangerous situation called hyperfibrinolysis. Now, where ROTEM gets really powerful is that it lets us ask more specific questions using different tests. For a liver transplant, the 2 most critical ones are EXTEM and FIBTEM. EXTEM gives you that big picture, the overall strength of the clot with everything working together. But FIBTEM
FIBTEM is the really clever one. It chemically knocks out the platelets so you can see only what the fibrinogen isn't doing, the mortar that's holding the whole thing together. This lets you spot a fibrinogen problem with incredible precision. Okay, so we've got this incredible tech that tells us a clot's life story in just a few minutes. How does it actually change things in the OR when the pressure's on? Well, this chart shows the single biggest impact right off the bat. Study after study shows that when you use ROTEM-guided treatment, the amount of fresh frozen plasma, or FFP, you transfuse just plummets. Instead of giving plasma because of some misleading number, doctors can now see that the overall clot is actually okay, and they can avoid giving products the patient doesn't need. And this leads to this fundamental shift in strategy. You move away from that old blanket approach of just throwing plasma at the problem, and you move towards a targeted, laser-focused approach. Thanks to tests like FIBTEM, you can see if the specific issue is a lack of fibrinogen. And if it is, you can give a precise dose of what's needed, like fibrinogen concentrate or cryoprecipitate, giving the patient exactly what they need and absolutely nothing they don't. So here's the crucial point. This isn't just about being more efficient or saving some blood products. This is about saving lives. A huge Cochrane review, which is basically the gold standard for evidence, found that using these kinds of tests to guide therapy was associated with a nearly 50% relative reduction in mortality. I mean, that is a staggering number. It just shows you the profound impact of having a clearer picture. But the story doesn't quite end there. You know, like with so many big advances in medicine, sometimes when you solve one problem, you end up uncovering a new, more subtle one. And this is the exact question that researchers started asking. Okay, so we've gotten really good at seeing the signs of bleeding and precisely fixing them, often with things that help clotting, right? But in that super fragile, rebalanced system, are we sometimes pushing that pendulum a little too far in the other direction? And this is what the data started to suggest. One really big study looked at patient outcomes before and after their hospital brought in a ROTEM-guided system. And just like we'd expect, the use of that targeted therapy, cryoprecipitate, went way up. But, and this is the alarming part, so did the rate of major clotting complications. We're talking about clots in the arteries of the brand new liver. That rate more than doubled from about 4% to almost 10%. And for the patients who got those clots, their one-year survival was significantly worse, which leaves us right here. ROTM has without a doubt revolutionized how we manage bleeding and liver disease. It gives us this targeted, life-saving approach that cuts down on needless transfusions. But it's also shown us just what a razor's edge these patients are on. Our amazing new ability to precisely fight back against bleeding might, if we're not incredibly careful, be pushing some patients right over the edge into the world of clotting. It's the ultimate clotting conundrum. And it just goes to show that even with our very best technology, we're still learning how to master this incredibly delicate dance.